Thank you all for joining today for the National DEB Talks happening on Translumina platform. Today we are going to, make this happen as all of the speakers, expert panelists, and moderator for the evening are from different regions of India. So that is why we are naming it as National DEB Talks. So before going ahead with the sessions today, I would just like to take you through what Translumina is actually. So a company with several solutions in coronary interventions, incorporated in the year 2000 with a presence of 50 plus countries, and it has been certified as a great place to work with, wherein 5 global manufacturing facilities are there with us and 3 indigenous manufacturing facilities. We do have a R&D excellence with German Heart Center and with 8 strategic partnerships. We do have also 10 years of clinical data of safety and efficacy with CE certified products. Over 1 million of implants we have already done with. Our manufacturing facilities are there in Germany and in Dehradun, India. As it has been the Asia's largest laser cutting facility, that's in Dehradun, India. Translumina has 10 years of clinical data of efficacy and safety, with world's #1 company to create 2 DES technologies with a 10-year safety efficacy data on stent to stent platform, that is Yukon Choice and Vivo SR, and also available in diabetic subset, CAC and ACS. So recently, just few months back only, Translumina has further strengthened its technology portfolio with acquisition of Blue Medical devices from Netherlands, and wherein we have a product named Protege, that is paclitaxel coated coronary balloon dilatation catheter, that has a global presence and it is EU MDR certified product. The presence of Protege has in more than 35 countries with R&D team in Netherlands, and manufacturing also is happening in Netherlands. Protege is, as mentioned, EU MDR certified, that is European Medical Device Regulation certified, and the technology is patented drug application process. Recently, we have come up for the domestic patients as well, Protege, which has unique drug application process, that is the one of the power technology that we do have, which is actually we have opted an auto pipette, which coats the balloon with the paclitaxel drug between the folds of the balloon, and that actually prevents and reduces the exposure and preventing loss prior to inflation. Then coming up with the wing seal technology, that is the patented technology that Protege has, that has actually the corrugation over the surface and increases the balloon's flexibility, overall the trackability and crossability. And tight wrapping of the balloon basically prevents unfolding during advancement. And due to all those 2 technologies, we have come up with M3A technology that actually allows 3 times inflation with the same balloon device in the same arterial segment. So today, as we are all here on behalf of Translumina, I welcome you all for taking your time out and giving the insights on drug-coated balloon in the era of modern PCI. So I would like to welcome Dr. Nikhil Kumar, Senior Director Cardiology Department from Fortis Hospital, Gurgaon. What to say about Sir? Sir is an all-round cardiologist with extensive experience in interventional, non-invasive, preventive and clinical cardiology, and Sir has an expertise in complex coronary angioplasty, including rotational arthrotomy, rotablation, that is, valvuloplasty, device closure of shunt lesions and pacemaker. And Sir has been associated with Fortis Hospital currently, and was associated as a professor and head of cardiology in Department of Army Hospital Research and Referral, New Delhi, that is. And earlier Sir was also associated with Metro Group of Hospital as the Director of Cardiology Department. And Sir is holding an experience of more than 40 years in cardiology segment. So Sir, over to you, Sir. I would request you to please take the session on, Sir.
Yeah, thank you, Garima, and thank you, Translumina, for bringing us all together. We have a very eminent group of cardiologists here, and all of them don't require any introduction. So the expert panelists would be Dr. Kalai Chelvan, Dr. Balaji, and Dr. Mehta. We would have talks by Dr. Sanjeev Gera, Dr. Zishan, Dr. Mansoori, Dr. Ahmed, and Dr. Ravikant. And again, a brief introduction. Dr. Ajit Mehta works in Jahangir Hospital, Pune, and he's a very very celebrated cardiologist there. Then we have Dr. Kalai Chelvan. He's a senior consultant intervention cardiologist at MMM Chennai. Again, does not require introduction. MMM is a great center to and I've been associated with a few people there. Dr. Balaji is a senior consultant and HOD coronary care unit with again Madras Medical Mission Chennai. Then Dr. Sanjeev Gera is one of the leading names in the field of cardiovascular sciences. He's the director HOD cardiology in our sister hospital in Noida. Dr. Zishan is an intervention cardiologist at the Narayana Multi-Speciality Hospital, Ahmedabad. Then Dr. Ahmed is a consultant interventional cardiology at the Bangalore Baptist Hospital. And Dr. Ravikant works with the Yashoda Hospital, Somajigoda. So I think that is the list of the eminent persons. And I think let me call on Dr. Sanjeev Gera. I think he's the opening batsman for today. And he would be talking on drug-coated balloons insights into emerging technologies.
Good evening. Thank you, Dr. Nikhil, for kind introduction, and thanks Garima and Translumina for having me here. I think my slides are visible.
Yes, sir.
Garima. So I will just not waste time and just surf through my slides. So my talk is basically on drug-coated balloons and some insights into the emerging technology. And we all know that we have evolved, the PCIs have evolved from the era of plain old balloon angioplasty to air metal stents, then first generation, second generation, and now more thinner stents. But we all know that the stents have got so much of limitations, like the rates of restenosis and especially stent thrombosis. These are actually not very low. We often see ISR around 10% over all PCIs. And then some challenging scenarios when we have small vessel disease and diffuse disease, especially in our Indian scenarios when we see a lot of diabetic CAD. So we are stuck whether to give full metal jacket to artery, especially LED. So this is a fascinating strategy, I think. And I think this is going to be the future of PCIs. So what is an ideal DCB? I think Garima has already made my job easier by introducing us about the Protage technology. So the ideal DCB should have an anti-proliferative drug, which usually is paclitaxel. There are so many trials on paclitaxel. Now they are doing it on Limus family also. And then this is very important that when drug is actually coated over the balloon, so there should be very minimal loss during transit, like when you are loading the balloon, when you are transiting it through your guide catheter to the distal, to the target lesion. So, and especially when there is a risk of particulate embolization and it can have systemic effects. So these things are to be actually considered whenever when you have any PCB technology. So tissue transfer efficiency also matters, the coating characteristics, whether it is hydrophilic or hydrophobic, because when it is hydrophilic, then there is the excipient. You always have to have some excipient so that it gets coated. Excipient is basically a carrier molecule. So when you have that hydrophilic excipient, the drug delivery is actually too fast over a shorter period of inflation. And then dose definitely matters, which paclitaxel has got the least dose per dose density. So this is the paclitaxel. This is a drug of choice. Many trials over paclitaxel as compared to sirolimus. The main difference between DCB and DS is the phase in which the drug interferes with the cell cycle and it basically stops the growth. So the protease interferes the cell growth, during the G1 phase of growth, and it just starts 4 hours after the procedure. But when we look at DES mechanism, it actually stops the growth during G2 and M phase, which actually takes 5 days after the procedure. And it is the most favorable drug as compared to sirolimus because it has got a shorter term exposure, higher absorption to the vessel wall, and it can actually reach to tunica adventitia. If you have prepared your lesion well, then it can actually reach to tunica adventitia. The half-life is around 6 to 13 hours, and a highly lipophilic compound which resides in the tissue for a prolonged period. And the effect actually wanes after 14 days. And it has been shown that after using this paclitaxel, you can have positive vessel remodeling over a period of time. Apoptosis risk is actually significantly reduced, and there is less of new growth, and it actually there is faster healing and faster endosterilization, so that you can actually reduce your dual antiplatelet therapy very early, especially when you have high bleeding risk scenarios. This is the same, like it hampers the growth during G1 and M phase of cell cycle. So why not Glimus family? You see this differentiating chart. Paclitaxel cutting balloon, paclitaxel coated balloon. It has got quicker tissue absorption with longer tissue retention as compared to sirolimus coating balloon, which has got slower tissue absorption and short tissue retention. And it is definitely more highly lipophilic than sirolimus. Broader therapeutic window is definitely with sirolimus, but many other effects like late vessel remodeling we actually often see with paclitaxel as compared to limus. So this has been explained by Garima, that it has got unique drug application, very minimal chances of drug loss during transit period because of that drug application. When you have wing seals technology, the transit is fast, trackability is very easy, and it has got M3 technology. You can have multiple inflation, especially 3 times inflation you can give in the same artery, and it has been suggested that you can actually use single balloon in different artery also when you plan to do both arteries or 3 arteries DCBs, PCIs. So now coming to DCB indications, and these are the DCB indications. Class 1 indications always is actually in-stent restenosis. We have enough of data like basket series of trials. Baskets, and then it also was actually shown that for small vessels also DCBs are an effective option. But for de novo lesions and bifurcation lesions and CTOs, it is an emerging technology. Many societies like Chinese DCB society, and then you have German PCI group. They actually recommend for de novo lesions and bifurcation lesions, but standard indication are in-stent restenosis and small vessels. So this is a strategy for appropriate use of DCB and DES in current practice. So you basically have to look at clinical presentation and angio and lesion characteristics. So when we have high bleeding risk patient, elderly patients, CKD patients who have already bled, then DCB only strategy is more beneficial. Hybrid therapy can be used, especially in younger ACS. When you have proximal significant LED disease, you can put a stent, and then you can just put DCB from mid to distal LED. DES only approach should definitely be reserved for highly ischemic risk patients. It will be more appropriate to use DES in such scenarios. For in-stent restenosis, small vessels, soft non-complicated lesions, DES is an emerging technology. We should actually consider DES for such scenarios. For bifurcation, still it is investigational, but it will give you less of carina shift, less of anatomy deformation, and there will not be any polymer disintegration between 2 strands. So there will be less chances of restenosis, which is actually very high during bifurcation stentings, and it will make the procedure very simple. I will just share a few of the cases done by us at Fortis Noida. We have been using DCB for last 2 years, but for last 6 months we have been using this paclitaxel DCB protage. This is case 1, PDA, 80% medium size vessel. So it is a large vessel. You can put stent. Earlier we used to put stent, longer stent, but why give stent in PDA, medium size vessel? So we decided to go with DCB. We prepared the lesion, and then you can see there is a little bit recoil. You will not get the result as good as with a stent, but definitely you can have positive remodeling after a few months. This is this lady presented to us with acute coronary syndrome with OM lesion, and she was uh, a 36-year-old lady. So we decided to go with the DCB, not put a stent in this lady because she was young, and why give a stent to her? So you can see we prepared the lesion well and put this paclitaxel balloon 2.530, and you can see very good result. There is a little bit of recoil, but it is good for her. And this is a case of LED diagonal bifurcation. You see LED diagonal bifurcation with small vessel diffuse disease. We wired both the vessels, prepared it well with NC balloon, then cutting balloons, and then we applied DCB 2.530 in LED and 2.5110 in diagonals. And you can see the final result. It is very well acceptable result. So this is a very interesting scenario when you want to avoid bifurcation stents, especially smaller stents, small size stents in these arteries. And this is LED D1 bifurcation. So I don't want to lose this diagonal, but simultaneously I don't want to put stent also for this diagonal. So we decided to go with stent to LED and DCB to diagonal. We actually prepared diagonal ostium with cutting balloon, then put a DCB in the diagonal. You can see an stent in the LED. You can see very beautiful result. And this person actually agreed for a check angio after 3 months. So we did a check angio. You can see very well positively remodeled diagonal. And the stent is flowing well. So that is how it made the job easier, and we avoided metal jackets. And this is RCA DCB in PDA, diffuse long disease in PDA. PLV, then why give 2 stents or multiple stents in such sized vessel? So any vessel which is less than 2.75 or less than 3 even, they call it a small vessel disease, but in our scenario maybe it is 2.75 or 2.5. So we did DCB, and we applied actually multiple inflations with this technology, and then we got a very good result with paclitaxel in this footage balloon. But we have to prepare the lesion very well with cutting balloon. So then we applied DCB, multiplication. This is the result. This is the final result, and it was satisfactory result. So another lesion, another case, and this was a guy, 38 years old, a doctor who presented to us with ACS of LED, but he had a high bleeding risk because he had alcoholic cirrhosis. He bled 2 months back, had some variceal ligation. He presented to us with LED ACS. You can see the lesion in LAC, thrombotic lesion. We prepared it with cutting balloon, and then we discussed with him whether you can go for DCB in the proximal LED because you are at a higher bleeding risk, low platelets, initial previous bleeding history. So I think this would be a better strategy for you. So he agreed to that, and we put a DCB, this protease 315 in the proximal LED. You can see not much recoil, very well flowing artery, no dissection, and no thrombus. So and he's doing well clinically. He agreed to us for like check angio after 3 months. He will definitely come for that. And this is distal RCA, same long disease. You can see the large RCA, PTA, long vessel, diffuse disease. So why give stents to this artery when you have this fascinating strategy? Prepare the lesion well with scoring balloons, multiple inflation with the same balloon, protease, and then you can see the final level. This is the final level. Beautifully flowing artery, no recoil, no dissection, no thrombs. So I think this is now going to be an upcoming strategy for all these type of scenarios. In summary, and this protease balloon has got a very innovative design, and that prevents drug loss during advancement, superb deliverability due to wing seal technology. You can have multiple drug releases, multiple inflation with the same balloon. It is hydrophilic and biocompatible, highly stable, and soluble in biological fluids. When we talk about the drug, it has got an advantage of late lumen enlargement as compared to sirolimus eluting balloon. It has been actually proved in one trial got reformed. Then less metal in complex PCIs, leave nothing behind approach is going to be definitely the strategy of the future. We can have less DAPT. You can stop DAPT after 1 month even of this in high bleeding risk patient. But ideally, DAPT should be given for 3 months after drug-coated balloon. Then you can make it a single antiplatelet, and it is going to be a treatment of choice for high bleeding risk patients, elderly patients, potential beneficial for younger patients. Small vessel diffuse hybrid technology we can use for LED proximal disease, and then put TCB in mid to distal LED for younger patients so that artery grows. And in case he wants to have CABG, or if he becomes a candidate for CABG, you can put a graft, surgeon can put a graft. So I think this is a unique technology with Protege balloon. They are coming up with NC Protege also, which has no balloon deformation up to RBP, and there will be no dog boning between NP and nominal pressure and rated pressure. So thank you very much for kind listening. I'm open to questions. Thank you very much.
Yeah, thank you, Dr. Sanjeev. I think that was a excellent presentation on the on the drug, the balloon, the design, and with very nice cases involving young people, high thrombotic risks, high bleeding risks, small vessels, diffuse disease, bifurcation lesions, and I think it was we stand to learn so much from it. I think we move on to the next talk, which is how do I expand this? 1 second. Yeah, how do I confidently expand my DCB practice, by Dr. Zishan Mansoori.
Hello, and thank you, sir, and thank you, everyone. So, are my slides visible?
Yes, they are.
Okay. So, I'll talk about how do I confidently expand my DCB practice. So, the steps basically to understand the evidence-based indications, to mastering the techniques and device selection, and investing in the imaging modalities, building a clinical experience with pilot cases, and then stay abreast with evolving technologies and trials, and documentation and publishing results. So, clinical guidelines to familiarize with the latest recommendations and guidelines from the bodies such as ACCH, AESC on the use of DCBs in the coronary artery disease, and key indications have been in-stent restenosis, small vessel disease, and bifurcation lesions. Emerging uses, there are ongoing trials to stay updated on the evolving indication for drug-coated balloon in case of complex lesions and high-risk patients as well. And how to master the techniques and device selection, appropriate patient selection, the patients who can benefit from the DCB therapy, particularly those with comorbidities, where reducing the stent usage is preferred. As Dr. Gera already mentioned, a patient with thrombocytopenia with a high thrombotic risk and ischemic events. Then optimizing the DCB delivery to develop a proficiency in the lesion preparation, including the pre-dilatation and assessment of vessel size to ensure that optimal drug delivery, and devices options, the different types of medication. So which drug-coated balloon for which drug-eluting stent in restenosis. And investment of intravascular imaging modalities, IVUS and OCTs utilize the imaging techniques like IVUS and OCT to optimize the interventions by identifying the lesion characteristics, guiding the preparation, and confirming the drug delivery. And these tools also help in choosing the cases where the drug-coated balloons are most effective and reducing the restenosis rates and complications. And build a clinical experience with pilot cases, starting small with a few straightforward cases for drug-coated balloon, and then progressively you can move on to the more complex lesions and review the outcomes regularly. As Dr. Kera had a patient who had come back for a check angio after 3 months. So monitor the patient outcomes, monitor the complications, monitor the restenosis rates, and make adjustments to your technique as necessary to optimize success. Stay abreast of evolving technologies and trials, clinical trials, follow the ongoing and upcoming trials, comparing the DCB outcomes with drug-eluting, and to understand where they may provide